Cancer isn't one disease, it's more than 100, and they all start the same way, with a single cell that stops following the rules. This series is a plain language tour of the major cancers and how they're treated. Quick but important note up front, this is educational, not medical advice. If it's about you or someone you love, talk to a real oncologist. Today, the foundation, what cancer actually is, and why one misbehaving cell can become life-threatening. It all starts with broken instructions. Every one of your cells carries a DNA instruction manual that tells it when to grow, when to stop, and when to quietly die and be replaced. Cancer begins when mutations corrupt that manual. Two kinds of genes matter most. Oncogenes are the accelerator. When they're damaged, they get stuck on, telling the cell to keep dividing. Tumor suppressor genes are the brakes. When they break, there's nothing left to stop the growth. It usually takes several of these hits accumulating in the same cell, over years, before things go truly wrong. That's a big reason cancer risk climbs as we age. Mutations pile up over a lifetime. Scientists boil the behavior of cancer down to a set of shared traits, often called the hallmarks of cancer. A cancer cell learns to grow without any signal telling it to, and to ignore the signals telling it to stop. It refuses to die, dodging the built-in self-destruct program that healthy cells obey. It divides endlessly, bypassing the limit on how many times a normal cell is allowed to copy itself. It builds its own blood supply, growing new vessels to feed the tumor. It learns to invade nearby tissue and spread to distant ones. And, remarkably, it learns to hide from the immune system. No single trait defines cancer, it's a cell that has collected enough of them to break free of the body's control. Not every lump is cancer, and this distinction matters enormously. A benign tumor is an overgrowth of cells that stays put. It can still cause real problems, pressing on a nerve, a blood vessel, or an organ, but it doesn't invade neighboring tissue and it doesn't spread. A malignant tumor is what we actually mean by cancer. It invades the surrounding tissue like roots, and it can break off and seed brand new tumors in distant parts of the body. That single capacity, the ability to spread, is the dividing line between a growth that's a nuisance and one that's a threat. So let's talk about the step that makes cancer deadly, metastasis. This is when cancer cells break away from the original tumor, slip into the bloodstream or the lymphatic system, travel to a distant organ, and start a new colony there, most often in the lungs, the liver, the bones, or the brain. Here's the sobering part, the great majority of cancer deaths are caused not by the original tumor, but by this spread. A breast tumor is rarely what's fatal, breast cancer that has spread to the bones or the liver is. That's why catching cancer before it spreads changes everything, and why so much of treatment is a race against metastasis. Once cancer is found, doctors describe it with two numbers. Staging asks how far it has spread, usually running from stage 1, small and still local, to stage 4, meaning it has reached distant organs. Stage is the single biggest driver of both prognosis and the treatment plan. Grading asks a different question: how abnormal do the cells look under the microscope? Low-grade cells still resemble normal tissue and tend to behave more calmly. High-grade cells look chaotic and tend to grow and spread faster. Together, stage and grade turn cancer from a scary word into a specific, describable problem, which is the first step toward treating it. And that's where we're headed next. Remember, this is educational, not medical advice. Last episode we saw what cancer is. Now, how do doctors sort more than 100 cancers into a handful of families? The key idea is that a cancer is named for the type of cell it started in, not the part of the body it ends up in. That's why cancer that spreads from the breast to the lungs is still called breast cancer. Let's meet the major families. Start with the big one, carcinomas. These begin in epithelial cells, the cells that line your organs, cover your skin, and make up your glands. Because epithelial tissue is everywhere, and because it's constantly renewing itself, carcinomas are by far the most common group, making up the large majority of all human cancers. Almost every cancer you've heard of, breast, lung, prostate, colon, pancreatic, is a carcinoma. You'll sometimes hear finer labels: an adenocarcinoma starts in gland cells that secrete something, while a squamous cell carcinoma starts in the flat lining cells. If you understand carcinomas, you understand most of oncology. The second family is sarcomas. These arise not in the linings, but in the body's connective and supporting tissue, bone, muscle, fat, cartilage, and blood vessels. Sarcomas are far rarer than carcinomas, they can show up almost anywhere in the body, and they more often affect children and younger adults. Because they're uncommon and biologically diverse, they're usually managed at specialized sarcoma centers, where teams see enough cases to know these cancers well. They're a small slice of the total, but an important one. Then there's a whole set of cancers that don't form a solid lump at all, the blood and immune system cancers. Leukemia is cancer of the blood-forming cells in the bone marrow. It floods the bloodstream with abnormal white blood cells that crowd out the healthy ones. Lymphoma is cancer of the lymphatic system, the network of lymph nodes and vessels that's a core part of your immune defense. It often shows up first as a swollen, painless lymph node. And myeloma is cancer of plasma cells, the antibody-making cells that live in the bone marrow, which is why it tends to damage the bones. These behave very differently from solid tumors, and we'll give them their own episode later. A few families sit in a category of their own. Central nervous system tumors, the cancers of the brain and spinal cord, are grouped separately, because their location makes them uniquely dangerous. A brain tumor can be devastating even when it never spreads anywhere else, simply because of where it is and how little room the skull allows. Melanoma, which starts in the pigment-producing cells of the skin, is treated as its own distinct and serious group rather than lumped with ordinary skin cancer. And there are others, like the germ cell tumors of the testes and ovaries. The point isn't to memorize the list, it's to see that the family a cancer belongs to shapes how it behaves and how it's treated. The most useful way to hold all of this in your head is one simple split, solid versus liquid. Solid tumors, the carcinomas, sarcomas, and brain tumors, form a mass you can often see on a scan and sometimes remove with surgery. The blood cancers are liquid, they're spread through the bloodstream and bone marrow essentially from the start. That single difference drives the entire treatment strategy. You can cut out a solid tumor, you cannot cut out a cancer that lives in the blood, so those are treated with medicines that reach the whole body. Keep that solid versus liquid distinction in mind, it explains a lot of what's coming. And remember, this is educational, not medical advice. Before we go cancer by cancer, let's build the toolkit, because almost every treatment plan you'll ever hear about is a combination of the same handful of tools. There are essentially 7, and the art of oncology is choosing which ones, in which order, for which patient. Let's walk through them, and the 2 questions that decide how they're used. The first 2 tools are local, they treat one specific spot. Surgery physically removes the tumor, and for many solid cancers caught early, it's still the single best shot at a cure. If you can cut it all out before it spreads, you may be done. Radiation therapy is the second local tool, precisely aimed beams of high-energy radiation that damage the DNA of cancer cells in one targeted area. It's used to shrink a tumor, to destroy one that can't be safely removed, or to mop up stray cells after surgery. Both are powerful, but both only treat what they can reach. For cancer that has spread, you need tools that travel through the whole body. The next 4 tools are systemic, medicines that travel through the bloodstream to reach cancer anywhere in the body. Chemotherapy is the classic one, drugs that kill fast-dividing cells. It's broad and genuinely effective, but because it hits every fast-growing cell, including hair, gut lining, and blood cells, it causes the side effects everyone associates with cancer treatment. Targeted therapy is more surgical, drugs designed to jam one specific molecular flaw that's driving a particular cancer, while largely sparing normal cells. Immunotherapy takes a completely different angle. Instead of attacking the cancer directly, it unleashes the patient's own immune system to do it. And hormone therapy starves cancers that run on hormones, like many breast and prostate cancers, by cutting off their fuel. We'll spend whole episodes on these. The 7th tool is more specialized, the stem cell, or bone marrow, transplant. For certain blood cancers, doctors deliberately use very high doses of chemotherapy or radiation to wipe out the diseased bone marrow entirely, and then rescue the patient by infusing healthy blood-forming stem cells, either the patient's own, collected earlier, or a donor's. Those cells migrate to the marrow and rebuild a healthy blood system. It's one of the most intense treatments in all of medicine, with real risks, but for some patients it's curative where nothing else is. So how do oncologists actually choose? 2 questions frame almost every plan. First, is the goal curative or palliative? Curative treatment aims to eliminate the cancer entirely. Palliative treatment, and this is not the same as giving up, aims to control the cancer and preserve quality of life when a cure isn't realistic, and it can add good years. Second, what's the timing around surgery? Treatment given before surgery, to shrink a tumor and make it removable, is called neoadjuvant. Treatment given after surgery, to kill any microscopic cells left behind and lower the chance of return, is called adjuvant. Almost every real-world plan is some combination of these tools, sequenced by those two questions. The single most important thing to take away is that modern cancer care almost never relies on one tool alone. A single patient's plan might combine surgery to remove the main tumor, chemotherapy to catch what spread, radiation to secure the original site, and then years of hormone therapy to keep it from coming back. That's why a cancer team includes surgeons, radiation specialists, and medical oncologists all at once. From here, the series goes cancer by cancer, breast, lung, prostate, and the rest, and you'll see these same 7 tools combined in different ways each time. As always, this is educational, not medical advice. Breast cancer is one of the most common cancers in the world, and one of the great success stories of modern treatment. Survival has climbed dramatically over the past few decades. A big reason is that doctors stopped treating it as one disease. Under the microscope and at the molecular level, breast cancer is really several different diseases, and knowing which one a patient has completely changes the treatment. The moment breast cancer is diagnosed, the tumor tissue is tested for 3 key markers, and the results decide everything that follows. The first 2 are hormone receptors, for estrogen and progesterone. The third is a protein called HER2, which, when there's too much of it, drives the cancer to grow aggressively. Whether a tumor has hormone receptors, has extra HER2, both, or none of them sorts it into subtypes that respond to completely different medicines. This is precision medicine in everyday practice. The same test result that names the cancer also points to its treatment. So here are the main subtypes. Hormone receptor positive breast cancer is the most common. It's fueled by estrogen, which sounds bad but is actually a gift, because you can block that fuel. The HER2 positive type is driven by that overactive HER2 protein. It used to be one of the scariest diagnoses, and it became one of the most treatable once drugs that specifically target HER2 arrived. And then there's triple-negative breast cancer. It has none of the 3 markers, which means the targeted and hormonal drugs don't work on it. It tends to be more aggressive and more common in younger women, and it's treated mainly with chemotherapy, now increasingly combined with immunotherapy. Same organ, 3 very different diseases. Whatever the subtype, treatment usually starts locally, with surgery. This ranges from a lumpectomy, removing just the tumor and a rim of healthy tissue around it, up to a mastectomy, removing the whole breast. One of the most important findings in cancer history is that for many women, a lumpectomy followed by radiation gives survival just as good as removing the entire breast. That spared countless patients the disfiguring surgery that was once standard. Surgeons also check the nearby lymph nodes, because whether the cancer has reached them is one of the strongest signals of whether it has begun to spread. Then comes the systemic attack, tailored to the subtype. For hormone receptor positive cancer, the workhorses are drugs that block estrogen, tamoxifen, or a class called aromatase inhibitors. Patients often take these as a daily pill for 5 to 10 years after their main treatment, and that long tail of hormone blocking is a big part of why recurrences have dropped. For HER2-positive cancer, antibody drugs, the best known is trastuzumab, sold as Herceptin, lock onto the HER2 protein and shut its signal down. When those drugs arrived, they turned one of the worst breast cancer subtypes into one of the most survivable. It's one of targeted therapy's clearest wins. The through line for breast cancer is test, then treat. The tumor's biology is read first, its receptors, its HER2 status, sometimes a genetic test of the tumor to estimate whether chemotherapy will even help, and only then is the treatment matched to it. Combine that with early detection through mammogram screening, which finds many cancers while they're small and curable, and you get the reason survival keeps climbing. Breast cancer is, in a real sense, the template for everything precision oncology is trying to do everywhere else. As always, this is educational, not medical advice. Screening decisions are a conversation to have with your own doctor. Lung cancer is the leading cause of cancer death worldwide. It kills more people than breast, prostate, and colon cancers combined. For decades it was a near-hopeless diagnosis. But in the last 15 years, few areas of oncology have changed as dramatically, because lung cancer turned out to be full of exactly the molecular targets that modern drugs are built to hit. The first thing to know is that lung cancer is really two different diseases. Non-small cell lung cancer makes up the large majority of cases. It grows and spreads relatively more slowly, and crucially, it's where the revolution has happened. The targeted and immune therapies will get to work mostly here. Small cell lung cancer is less common but much more aggressive. It grows fast, spreads early, and is very strongly tied to smoking. It's usually treated with chemotherapy and radiation, and while it often responds well at first, it tends to come back. When people talk about the exciting progress in lung cancer, they're mostly talking about the non-small cell type. Here's what changed everything. When a non-small cell lung cancer is diagnosed today, the tumor is routinely sent for genomic testing, reading its DNA to look for specific driver mutations. These are the single broken genes that a particular tumor depends on to grow. In the lung, the famous ones go by names like EGFR, ALK, ROS1, and KRAS. And the reason we look is simple and powerful. If the tumor has one of these drivers, there is often a targeted pill designed to shut that exact driver off. A patient whose cancer is driven by EGFR can sometimes take a daily tablet that holds the disease back for years, with far gentler side effects than chemotherapy. That was unthinkable not long ago. But not every lung cancer has a neat targetable driver. For many of those, the answer has been immunotherapy, and lung cancer is one of the diseases where it truly broke through. These drugs, which we'll dig into later, release the brakes on the immune system so it can recognize and attack the tumor. For a meaningful share of patients, they produce durable, long-lasting responses, some people years out and still doing well, the kind of outcome that chemotherapy alone almost never delivered in advanced lung cancer. Often immunotherapy is combined with chemotherapy for an even better shot. Between targeted pills and immunotherapy, advanced lung cancer went from a diagnosis measured in months to one where long-term control is genuinely possible. There's one more piece, and it's about catching lung cancer early. The tragedy of this disease has always been that early lung cancer causes no symptoms, so it's usually found late, after it has spread. The fix is screening, a quick, low-dose CT scan of the chest, offered to people at high risk, typically older adults with a heavy smoking history. Done in the right population, this screening finds tumors while they're small and still curable by surgery, and it measurably lowers the death rate. It's the same lesson as mammograms and colonoscopies. For the people most at risk, looking before there are symptoms saves lives. For all the dazzling progress in treatment, the biggest lever against lung cancer is still prevention. The overwhelming majority of cases are linked to smoking, though it's important to say that lung cancer does occur in people who never smoked, and those cases actually tend to be the ones driven by targetable mutations. Quitting matters at any age, the risk starts falling within years of stopping. So the honest summary of lung cancer today is a hopeful one: better screening to catch it early, and a treatment toolkit, targeted pills, immunotherapy, chemotherapy, surgery, and radiation, that has rewritten what a diagnosis means. This is educational, not medical advice. Prostate cancer is one of the most common cancers in men, and one of the most misunderstood. Its defining feature is a paradox. Many prostate cancers grow so slowly that they'll never cause harm in a man's lifetime, while a minority are genuinely aggressive. The whole challenge of this disease is telling those two apart, and not overtreating the harmless kind. Let's start with that paradox. The prostate is a small gland that sits below the bladder and makes part of the fluid in semen. A great many prostate cancers are what doctors call indolent. They grow so slowly that a man is far more likely to die with the cancer, of something else entirely, than to die from it. But a real minority are aggressive. They grow quickly and can spread, particularly to the bones. So the central problem in prostate cancer isn't finding it, it's figuring out which kind you're dealing with, because treating a harmless cancer aggressively can cause more harm than the cancer ever would. The main tool for detection is a simple blood test measuring PSA, prostate-specific antigen, a protein the gland makes. A raised PSA level can be a sign of cancer. But, and this is important, it can also just mean the prostate is enlarged with age, or inflamed, so PSA is an imperfect screen that has led to a lot of unnecessary worry and treatment over the years. When there's real concern, the next steps are an MRI scan and a biopsy, where small tissue samples are examined under the microscope. A pathologist scores how abnormal and disorganized the cells look. That score is the best early read on whether this cancer is the lazy kind or the dangerous kind. Here's where prostate cancer teaches a lesson the rest of oncology is still learning. For low-risk disease, the best option is often to do no immediate treatment at all, an approach called active surveillance. That doesn't mean ignoring it. It means carefully monitoring the cancer with regular PSA tests, scans, and sometimes repeat biopsies, and stepping in with treatment only if it actually starts to progress. Why hold back? Because the main treatments, surgery and radiation, carry real, life-altering side effects, including urinary incontinence and erectile dysfunction. For a cancer that may never threaten the man's life, active surveillance spares him those harms. Choosing to watch, on purpose, is genuinely the right medicine here. For the cancers that do need treatment, the options track the toolkit we built earlier. If the cancer is localized but aggressive, the main choices are surgery to remove the prostate, increasingly done with robotic assistance, or radiation therapy, and the two give broadly similar cure rates for many men. And when prostate cancer has spread beyond the gland, the backbone of treatment is hormone therapy. This is one of oncology's oldest targeted ideas. Prostate cancer runs on testosterone, so drugs that shut off testosterone can starve the cancer and hold it back, often for years. Newer hormonal drugs and chemotherapy extend that control further when it's needed. So the big takeaway from prostate cancer is one of the most important ideas in all of oncology: more treatment is not always better treatment. The entire strategy is to match the intensity of the treatment to the actual risk of the cancer, to treat the aggressive ones hard and early, and to leave the harmless ones alone under careful watch. It's a discipline driven by evidence rather than by fear, and it spares enormous numbers of men from side effects they never needed. If you're a man weighing PSA testing or a diagnosis, that risk conversation is exactly what to have with your doctor. This is educational, not medical advice. Colorectal cancer, cancer of the colon and rectum, is one of the most common cancers, and one of the leading causes of cancer death. But it has a remarkable feature that sets it apart: it's one of the few cancers we can often prevent entirely, by finding and removing its precursor before it ever becomes cancer. That single fact makes it one of the most important cancers to understand. The key to colorectal cancer is understanding how it develops, because that's what makes it preventable. Most of these cancers begin as a polyp, a small, initially harmless growth on the inner lining of the bowel. Over a span of years, and through a well-understood sequence of mutations, some polyps gradually turn cancerous. That's the crucial detail: the process is slow, and it's predictable. There's a long window, often a decade, between a benign polyp appearing and it becoming a dangerous cancer. And a slow, visible, predictable precursor is exactly the opening that a good screening program can exploit. This is why colorectal screening is special. Most cancer screening only detects cancer earlier. Colonoscopy can actually prevent it. During a colonoscopy, a doctor guides a flexible camera through the colon and inspects the entire lining, and if they spot a polyp, they can remove it right then and there, before it ever has the chance to become cancer. That's prevention, not just detection. There are also simpler, less invasive options: stool-based tests done at home that check for hidden blood or for cancer DNA shed into the stool. Those are easier to do, and if one comes back positive, it's followed up with a colonoscopy. The message from doctors is blunt: getting screened on schedule is one of the most effective cancer prevention steps that exists. When colorectal cancer is actually found, the cornerstone of treatment is surgery, removing the affected segment of the bowel and reconnecting the healthy ends. Caught early, before it has spread, that surgery alone is often curative, which is another reason early detection matters so much. If the cancer has reached the nearby lymph nodes or grown deeper into the bowel wall, chemotherapy is usually added after surgery, that adjuvant approach we talked about, to kill any microscopic cells left behind and cut the risk of the cancer coming back. For rectal cancer specifically, radiation often joins the plan as well, because of the tighter space it sits in. For colorectal cancer that has spread, treatment gets more personalized, and it echoes the precision medicine theme running through this series. The tumor is tested for specific markers. Mutations in a gene family called RAS, for instance, determine whether a certain class of targeted antibody drugs will work. If the RAS gene is mutated, those particular drugs won't help, so testing prevents wasted treatment. Other drugs block the tumor's blood supply. And there's a standout subset: cancers with a feature called MSI-high, meaning they carry a specific DNA repair defect. These tumors turn out to respond remarkably well to immunotherapy, a striking result that helped prove immunotherapy could work in a cancer well beyond melanoma and lung. The takeaway for colorectal cancer is genuinely empowering. Here is a common, deadly cancer that is highly treatable when caught early, and often preventable altogether, because we can find and remove its precursor. One worrying trend worth knowing: colorectal cancer has been rising in younger adults, for reasons researchers are still working out, and that's why screening guidelines in many places now start at a younger age than they used to. So if you're of screening age, or you have a family history, or you have persistent symptoms, this is the cancer where acting early has an outsized payoff. As always, this is educational, not medical advice. Talk to your doctor about when your screening should begin. Skin cancer is the most common cancer of all, more people get it than any other type. And most of the time it's very treatable. But hidden within that reassuring picture is melanoma, a much less common form that is far more dangerous, and one that has become a showcase for the most exciting advances in modern cancer treatment. Understanding the difference could genuinely save your life. Let's clear up the categories, because the word skin cancer covers very different things. The two common types are basal cell carcinoma and squamous cell carcinoma. Together these make up the vast majority of skin cancers. They arise in the outer layers of the skin, typically on the areas that get the most sun: the face, ears, neck, and hands. The good news is that they grow slowly and locally, and they very rarely spread to the rest of the body, so they're rarely life-threatening. But they do keep growing and can damage tissue if ignored, so they still need to be removed. These are the skin cancers most people will encounter. Then there's melanoma, and this is the one to take seriously. Melanoma begins in the melanocytes, the cells that produce the pigment that colors your skin, which is why it often appears as a new mole, or as an existing mole that starts changing. It's far less common than the basal and squamous types, but it accounts for the large majority of skin cancer deaths. The reason is simple and dangerous: unlike the common skin cancers, melanoma can spread early, traveling to the lymph nodes and then to distant organs while the spot on the skin still looks small. Caught early, melanoma is usually cured by simple surgery. Caught late, it used to be one of the deadliest cancers there was. Because catching melanoma early matters so much, there's a simple checklist worth memorizing: the ABCDES of moles. A is for asymmetry, one half doesn't match the other. B is for border, the edges are irregular, ragged, or blurred rather than smooth. C is for color, there's more than one color, or uneven shading. D is for diameter, it's larger than a pencil eraser, though melanomas can be smaller. And E, the most important, is for evolving, any mole that is changing, in size, shape, or color, or any spot that's brand new and looks different from your others. If something on your skin fits these, it's worth having a dermatologist look. Removal and examination of a suspicious spot is quick and low risk. Here's the part that makes melanoma one of the most important cancers in modern medicine. Just over a decade ago, melanoma that had spread was close to a death sentence, measured in months. Then it became the proving ground for immunotherapy. Drugs called checkpoint inhibitors, which release the brakes on the immune system, produced something almost unheard of in advanced cancer: lasting remissions, with some patients still cancer-free many years later. On top of that, about half of melanomas carry a specific mutation in a gene called BRAF, and targeted drugs that switch off that mutation can shrink tumors dramatically and fast. Between immunotherapy and BRAF-targeted therapy, melanoma went from hopeless to a disease where long-term survival is real. It's the clearest proof of what the new tools can do. So the takeaway splits neatly in two. On prevention, the overwhelming driver of skin cancer is ultraviolet exposure, from the sun and from tanning beds, so sun protection, shade, and skipping the tanning bed genuinely lower your risk, especially the cumulative damage that adds up over a lifetime. And on detection, because early melanoma is so reliably curable with minor surgery, the single highest value habit is simply knowing your own skin, noticing change, and getting anything suspicious checked promptly. Skin cancer is the cancer you can most often see with your own eyes, which is a real advantage, if you use it. This is educational, not medical advice. So far we've talked about solid tumors, lumps you can scan and often cut out. Blood cancers are different in a fundamental way: they arise in the cells of the blood and immune system, so they're spread through the body from the very start. You can't remove them with surgery. But some of oncology's greatest triumphs, and some of its most futuristic treatments, live right here. Let's meet the three main families. First, leukemia, cancer of the blood-forming cells in the bone marrow. The marrow starts churning out abnormal white blood cells that don't work and don't stop multiplying, and they crowd out the healthy cells the body needs, leading to anemia, infections, and bleeding. The most important split is between acute and chronic. Acute leukemias come on fast and aggressively, and they're a medical emergency requiring immediate, intensive treatment. Chronic leukemias develop slowly, sometimes over years, and some are so indolent that, like low-risk prostate cancer, they're simply monitored at first. You'll hear four main types named by letters, but the big idea is that same acute versus chronic divide: how fast is it moving? The second family is lymphoma, cancer of the lymphatic system, the network of nodes and vessels that's part of your immune defense. It often shows up as a painless, swollen lymph node in the neck, armpit, or groin. Lymphoma splits into two broad groups. Hodgkin lymphoma, which tends to strike younger people, is one of the true success stories of oncology. It's now one of the most curable of all cancers. The non-Hodgkin lymphomas are a large, varied group that ranges from slow and indolent to fast and aggressive. The third family is myeloma, a cancer of plasma cells, the cells that make antibodies. Because plasma cells live in the bone marrow, myeloma characteristically eats away at the bones, causing pain and fractures, and it remains treatable but generally not curable. Now for one of the most important stories in all of cancer medicine, and it happened in a blood cancer. Chronic myeloid leukemia is driven by one specific abnormal protein, produced by a single genetic accident. In the early 2000s, a drug called imatinib, brand name Gleevec, was designed to block that exact protein. The result was staggering: a leukemia that used to be fatal became a manageable condition, controlled by a daily pill, with many patients living a near-normal lifespan. It was the proof of concept for the entire idea of targeted therapy: find the one molecular flaw driving a cancer, and design a drug to shut it off. Much of modern precision oncology traces back to this one leukemia. Blood cancers are also where the most dramatic treatments live. The stem cell transplant, which we introduced earlier, wipes out the diseased marrow with very high-dose therapy and then rebuilds the blood system from healthy donor or patient stem cells, and for some leukemias and lymphomas, it's curative. And then there's the newest frontier, CAR T-cell therapy. Here, doctors collect a patient's own immune T-cells, genetically re-engineer them in the lab to recognize the cancer, grow them by the millions, and infuse them back in as a living drug that hunts the disease. In some patients with leukemia, lymphoma, or myeloma who had exhausted every other option, CAR T-cells have produced complete remissions. We'll come back to how it works, but it started here, in the blood cancers. So the takeaway for blood cancers flips the usual intuition. Yes, they're frightening in that you can't point to them or cut them out, they're everywhere in the blood and marrow from the start. But that same feature means they're treated entirely with systemic medicine, and that is precisely the arena where targeted drugs, transplants, and cell therapies are most powerful. From Hodgkin lymphoma, now among the most curable of all cancers, to chronic leukemia controlled for decades by a daily pill, many blood cancers are among the most treatable there are, and they've repeatedly been the place where the future of cancer treatment arrived first. This is educational, not medical advice. We've spent several episodes on genuine progress, cancers that are now caught early, targeted precisely, or even cured. But honesty matters, so this episode is about the other side, the cancers where survival is still poor despite everything we've thrown at them. Pancreatic, liver, brain, and ovarian cancer. Understanding why they're so hard is the key to understanding where cancer research most urgently needs to go. Start with the thread that ties most of these together: they're caught too late. The single biggest reason a cancer is deadly is often not that it's untreatable in principle, but that it's found after it has already spread. Pancreatic and ovarian cancer are the classic examples. The pancreas and ovaries sit deep in the body, and tumors there cause almost no symptoms until they're large or have spread, by which point the vague signs, like back pain, bloating, or weight loss, are easy to mistake for something ordinary. So by the time these cancers are diagnosed, the window when surgery might have cured them has usually already closed. Late detection is the first, and often the decisive, disadvantage. Take pancreatic cancer specifically. It's a kind of worst case. It's usually found late, its cells are wrapped in a dense, protective tissue that physically keeps chemotherapy out, and it has so far lacked the neat targetable mutations that transformed lung cancer and melanoma. That combination gives it one of the lowest survival rates of any major cancer, and it's why it remains a top research priority. Liver cancer carries a different burden. It very often develops in a liver that's already damaged and scarred by cirrhosis, from chronic hepatitis or heavy alcohol use, which means the organ is frail to begin with, limiting how aggressively doctors can treat the cancer without the liver itself failing. In both, the disease and the setting conspire against treatment. Then there's glioblastoma, the most aggressive brain cancer, and it's hard for reasons all its own. First, it doesn't form a neat, removable ball, it sends microscopic tendrils weaving into the surrounding healthy brain, so no surgeon can ever cut out every last cell without destroying the brain itself. Second, the brain is guarded by the blood-brain barrier, a natural filter that protects it from toxins in the blood, but that same barrier blocks many cancer drugs from ever reaching the tumor. And third, you simply can't be as aggressive in the brain as elsewhere, because the healthy tissue right next to the tumor controls who the person is. Despite decades of effort, survival has barely budged, which is why glioblastoma is one of the field's most painful challenges. Beyond late detection and difficult locations, these cancers share a deeper problem: they tend to be genetically messy and highly adaptable. Rather than depending on one clean driver mutation, they carry many, and they evolve, so a treatment that shrinks the tumor at first is often outmaneuvered as resistant cells take over. That said, this isn't a hopeless story. Hope is coming from several directions: earlier detection, including the liquid biopsies we'll discuss next episode that hunt for cancer DNA in the blood before symptoms appear, new ways to sneak drugs across the blood-brain barrier, and efforts to make immunotherapy work in tumors that have so far shrugged it off. Every one of these cancers is a major focus of research precisely because the need is so great. The honest takeaway is that progress against cancer has been real, but deeply uneven. For some cancers, the last 2 decades have been revolutionary. For pancreatic, liver, brain, and ovarian cancer, gains have been hard-won and incremental. Holding both of those truths at once is what it means to understand cancer clearly, neither the hype that says it's solved, nor the despair that says nothing works. For patients facing these harder diagnoses, clinical trials often provide access to the newest approaches and are well worth asking about. And these are exactly the cancers where earlier detection and fresh science could change the most lives in the years ahead. This is educational, not medical advice. For a century, cancer treatment meant attacking the cancer directly: cut it out, burn it with radiation, poison it with chemotherapy. Immunotherapy is a completely different idea. Instead of attacking the cancer, you unleash the patient's own immune system to do it. It has produced some of the most astonishing results in all of medicine, and it earned a Nobel Prize. Let's understand how it actually works. To understand immunotherapy, you first have to understand why the immune system lets cancer grow in the first place. Your immune system is a superb hunter of anything foreign: viruses, bacteria, infected cells. But cancer is a tricky enemy, because it isn't foreign. It's your own cells, gone wrong, so it looks a lot like normal tissue, and the immune system hesitates to attack it. And cancer doesn't just hide passively, it fights back. Tumors learn to send out molecular signals that actively switch off any immune cells that come close, essentially flashing a fake "do not attack" badge. So the problem isn't that the immune system can't kill cancer. It's that cancer has learned to talk it out of doing so. That insight led to the first big breakthrough: checkpoint inhibitors. Immune cells come with built-in safety switches called checkpoints, off switches that normally exist to stop the immune system from attacking your own healthy tissue. They're the brakes that prevent autoimmune disease. The discovery that won the Nobel Prize was that cancers hijack those very brakes: they press the immune system's off switch to protect themselves. So the drug idea is elegant. Checkpoint inhibitors block the off switch, they release the brakes, freeing the immune system to see the cancer for what it is and attack it. Note what this means: the drug doesn't touch the cancer at all. It just takes the muzzle off the immune system. And in cancers like melanoma and lung, that alone can produce lasting remissions. The second breakthrough goes even further: it doesn't just free the immune system, it rebuilds it. CAR T-cell therapy is one of the most futuristic treatments in medicine. Doctors collect a patient's own T-cells, the immune system's assassins, from their blood. In the lab, those cells are genetically reprogrammed, given a new molecular receptor that lets them recognize a specific marker on the patient's cancer. They're multiplied into the hundreds of millions, and then infused back into the patient as a living drug that circulates, hunts, and kills. For certain blood cancers, some leukemias, lymphomas, and myeloma, where every standard treatment had failed, CAR-T cells have driven patients into complete, lasting remission. It's a genuinely personalized therapy. The treatment is made from the patient's own cells. As remarkable as this is, honesty requires the limits. Immunotherapy is not a universal cure. For many patients, checkpoint inhibitors simply don't work, and we still can't fully predict in advance who will respond and who won't, a huge open research question. There's a real cost, too. When you release the immune system's brakes, it can start attacking healthy organs, causing serious inflammatory side effects that need careful management. And CAR-T cell therapy, for all its power, has so far mostly conquered blood cancers. Getting it to work against solid tumors like lung or pancreatic cancer has proven genuinely difficult, and it's one of the biggest goals in the field. This is a revolution in progress, not a finished one. The takeaway is that in barely more than a decade, immunotherapy has become a fourth pillar of cancer treatment, standing alongside surgery, radiation, and chemotherapy, and for some cancers it's now a first choice, not a last resort. Its signature gift is durability. Chemotherapy might shrink an advanced cancer for months. Immunotherapy, when it works, can hold it back for years, and a fraction of patients appear to be functionally cured of diseases that were once rapidly fatal. The frontier now is extending that success to more patients, and to the solid tumors that have resisted it. It's the treatment story most likely to define the next decade of oncology. This is educational, not medical advice. We'll finish the series by pulling the biggest thread of all together. Across these episodes, one idea kept returning: the most powerful treatments target the specific molecular flaw driving a cancer, not just the organ it grew in. That's precision oncology, and it's quietly rewriting how cancer is diagnosed and treated. Let's see where it's going, and how the future of catching cancer early is changing too. For all of history, cancer has been named and treated by its location: breast cancer, lung cancer, colon cancer, and the treatment followed that label. Precision oncology adds a second, deeper label: what's actually broken inside the tumor at the molecular level. We've seen this again and again in this series: the HER2 protein in breast cancer, the EGFR mutation in lung cancer, the BRAF mutation in melanoma, the abnormal protein in chronic leukemia. In each case, reading that molecular flaw pointed straight to a drug built to hit it. Precision oncology is the systematic version of that idea: sequence the tumor's DNA, find its specific drivers, and match the treatment to the biology rather than just the body part. Making this real depends on genomic testing, reading a tumor's DNA to reveal its mutations, often scanning hundreds of genes in a single test. The results can flag a targetable driver the doctor would never have guessed from the cancer's location alone. And this has led to something genuinely new in medicine: tumor-agnostic drugs. These are treatments approved not for a particular organ, but for any cancer that carries a specific molecular feature, no matter where in the body it started. If your tumor has the right marker, the drug is an option whether it's in your lung, your colon, or your thyroid. That's a profound shift. For the first time, a cancer's genetics can matter more than its address. One of the most exciting tools in this future is the liquid biopsy. Tumors constantly shed tiny fragments of their DNA into the bloodstream, and a liquid biopsy reads that circulating cancer DNA from an ordinary blood draw. Think about what that enables. Instead of a painful, sometimes risky tissue biopsy, you can profile a tumor's mutations from a vial of blood. You can repeat it easily to see whether a treatment is still working, or whether the cancer is evolving resistance, in near real time. And the most ambitious use, still being proven out, is early detection: multi-cancer blood tests that scan for the DNA of many cancers at once, aiming to catch them before symptoms ever appear. If that works reliably, it could do for many cancers what the colonoscopy did for the colon. All of this creates an ocean of data: genomic profiles, pathology slides, radiology scans, clinical records, far more than any human can fully read. And that's where artificial intelligence is increasingly stepping in, a theme our companion series on AI in drug discovery explores in depth. AI models help spot patterns in a pathologist's slides, flag tumors on a scan, sift a tumor's mutations for the ones that matter, and match patients to the clinical trials they're eligible for. The honest framing is the same one that runs through modern oncology. AI here is mostly a throughput tool, it makes the work faster and broader and more consistent, while the oncologist still frames the question and makes the call. Used well, it helps precision medicine actually scale to every patient. So here's this whole series in one line: cancer is being redefined from a disease of organs into a disease of molecules, one we're learning to catch earlier and treat more precisely with every passing year. We've gone from a single blunt question, where is it, to a richer one, what is broken inside it, and what exactly will shut that down? The progress is real, and it's uneven, spectacular for some cancers, still painfully slow for others, and the science is moving faster than ever. Whether you're a patient, a caregiver, or just someone who wants to understand the disease that touches nearly every family, that understanding is genuinely the best defense any of us has. Thanks for watching this series. And as always, this is educational, not medical advice.